Hello, this is Ruben Hernandez, Associate Professor at Michael E. DeBakey VA Medical Center and Baylor College of Medicine in Houston, Texas.
And my name is Amit Singal. I'm a professor of medicine at UT Southwestern Medical Center in Dallas, Texas.
Thanks, Amit. We are pleased to provide a video summary of our multicenter pragmatic randomized clinical trial published in GATT addressing the effectiveness of mail outreach and patient navigation to promote hepatocellular carcinoma screening process completion. Amit, what is already known of the effectiveness of outreach programs in hepatocellular screening?
Well, thanks, Ruben. So we know that HCC is one of the few cancers that continues to have a 5-year survival that remains below 20%. However, prognosis largely varies by the tumor stage at the time of diagnosis. So patients who are found early can have curative therapies available and achieve a survival well over 5, if not over 10 years. Therefore, early stage detection is critical, underscoring the importance of surveillance efforts. Unfortunately, we and others have consistently shown failures across the entire cancer care continuum, including underuse of HCC surveillance. In fact, we've shown that only 1 in 5 patients who are at risk for HCC receive surveillance as they should. Now, various interventions ranging from provider education to best practice alerts to mailed outreach have all been shown to be efficacious in prior studies.
So what do you think is missing?
Now, while these interventions have been shown to be efficacious, most studies have only looked at one-time screening or repeat screening over short periods of time, like 12 months. Indeed, few studies, if any, have evaluated efficacy over longer periods of time or across different healthcare systems. And these data are needed since we know that intervention effects can be mitigated over time. There can be downstream failures in the cancer care continuum, like diagnostic or therapeutic delays, and intervention effect can vary across healthcare systems. So we attempted to address this gap in the literature through our study, now available in GUT. Specifically, we conducted a multi-center pragmatic randomized clinical trial between April 2018 and September 2021, comparing mailed outreach plus patient navigation for HCC screening versus usual care among patients with cirrhosis at 3 U.S. healthcare systems. We looked at screening process completion over a 36-month period as our primary outcome, and our secondary outcome was the proportion of time covered by screening.
Excellent. Can you share what we found?
Yeah, so Ruben, as you know, our study included a total of 2,872 participants. They had a median age of 61 years, and just under 1/3 were women. You can see the rest of the patient characteristics included in the table here from our paper. All of these patients were included in intention to screen analyses. So the top line result was that screening process completion was observed in 6.6% of patients randomized to outreach and 3.3% of patients randomized to usual care, yielding an odds ratio of 2.05. The intervention increased HCC screening process completion across most subgroups, including age, sex, race and ethnicity, child pew class, and healthcare system. As a secondary outcome, proportion time covered was also significantly higher in the outreach arm versus the usual care, with means of 37.5% and 28.2% respectively. Now, the interpretation of these data likely depends if you're a half glass full or a half glass empty type person. The good news is that the intervention worked. It doubled HCC screening process completion. However, the disappointing and realistic news is that screening process completion was suboptimal in both arms. And I think overall, this highlights the difficulty of HCC screening process completion at regular intervals over long periods of time, like we've shown.
So thank you, Amit. So how do you think it might impact our clinical practice in the foreseeable future?
Yeah, so Ruben, I think from a clinical perspective, our study adds to existing literature showing that interventions can be efficacious to improve screening adherence. Now, I think it's time for healthcare systems to start considering which intervention would work best in their workflow and how they could consider implementing something in clinical practice. Now, as you know, this is actually recommended in the most recent AASLD guidelines for HCC management. From a research perspective, we need further work to improve surveillance effectiveness. Once again, 6.6% screening process completion over a 3-year period is far from where we need to be. Now, we can continue thinking through intervention strategies to improve adherence as we move forward, but I think this needs to be done in parallel with validation of emerging surveillance strategies, whether imaging-based or blood-based, and hopefully these newer surveillance strategies will be easier to implement in clinical practice, and we'll see higher adherence moving forward.
Thank you, Amit, for summarizing our trial. On behalf of the authors, we want to thank GATS and the reviewers for the opportunity to present the results of our trial. And for more information about our paper, you can visit gat.bmga.com or use this QR code shown in the slideshow. Thank you again for your attention.
Thank you.